try to move finally the case-based presentation. It might be, yes, much more interesting for you. So the current evidence, you may know this is Renovate a complex PCI from my friend Korea, right? They did the complex PCI imaging guide and angio guide 2-1. And the imaging guide group, nearly 2/3 IVAS and 1/3 OCT. It's depend on the operator's operator's decision. This is the data, right? Target vessel failure imaging guide is superior than the angio guide, as you may expect, and also procedure-related MIAS, except for the intervention event, right? And then this is a meta-analysis in each type, CTO, imaging better, and unprotected left main coronary imaging better, and also the diffuse long region imaging better, and severe calcification imaging guide is better. So generally speaking, imaging guide is better than angio guide. You can easily expect. This is another data comparison between FFR guide versus IVAS guide, recently published from Korea again. There are no significant difference. Therefore, you can use a physiology guide and imaging guide. It's no significant difference. But there are only one data showing the difference of an imaging guide and physiology guide. This is for the trial from Europe, and they try to divide imaging guide and physiology guide. Within 1 year, there are no significant difference, but the 2 years, there are some difference in TVF. So imaging is better than the physiology guide. And this is more details analysis. Finally, the primary endpoint, including MACE or significant angina, imaging guide is better than the physiology guide. The other, evidence, there are no significant difference. So they summarize, if you use the physiology guide, you can reduce the number of PCI, and medical treatment follow-up is increasing, no damage of the kidney, and also the total cost reduced. However, the evidence is a little bit higher than imaging guide. You use an imaging guide, number of PCI increase and the contrast volume increase, but the evidence is significantly lower. That is the difference between a physiology guide and imaging guide. This is another data showing the imaging guide, only the IVAS guide and angio guide. Compared with angio guide, IVAS guide is significantly lower evidence, lower TVF for 3 years. And also, even in IVAS guide, if we focus on the suboptimal result and optimal result is better compared with some optimal result. This already demonstrated by the ultimate study in China. This is an ultimate study for 3 years follow-up. There are no significant difference in cardiac death or target vessel MI. However, the target vessel failure imaging guide is significantly better than the angio guide, as you may easily expect. And there are lots of sub-analysis. It's a very busy slide, but you can easily identify there are all sub-analysis demonstrated IVAS is better than the angio guide. And this is an IVAS XPL randomized clinical trial. IVAS guide is better than angio guide, as you can expect, and similar to the previous data, optimal result is much better than the suboptimal result. So imaging is not perfect because we cannot completely finish the result. It depends on the condition. So sometimes suboptimal results can be demonstrated. And sub-analysis demonstrate there are significant difference. The final balloon size is bigger and maximum inflation pressure is higher, and also the reference vessel diameter or minimum lumen diameter is significantly bigger in IBUS guide, and also this is a result, and the minimum area and also the elastic membrane area or lumen area is smaller in the IBUS guide. And also this is adapt DS trial, as you know, using imaging the operator change the balloon within higher pressure, or if there are under expansion operator add the post dilatation. That is the main cause of the difference between imaging guide and angio guide, as you know very well. So let's move on the OCT guide. And this is an opinion trial comparison between IBUS and OCT guide. There are no significant difference. So this is a non-inferior study to demonstrate OCT compared with IBUS. This also the Illuminant 3 trial, as they compared IBUS guide, angio guide, and OCT guide. They are expecting there are no significant difference between IBUS and OCT, and both imaging guide is superior than angio guide, but they failed to demonstrate the superiority because of the small number. But they can demonstrate it, no significant difference in OCT guide and with IBUS guide. Based on these data, finally, ES consensus document demonstrate how to treat a lesion. As we already discussed from the morning, MSA should be 4.5 by OCT or 5.5 by IBUS, or 80% compared with reference area. But if possible, we try to get more than 90%. It is very important to obtain the much better result, and also the malposition should be less than 400 micron. I will show you why it's 400 micron, and also the plug burden should be less than 50% by IBUS, and also non-repeating by OCT. It is very important. If you identify the edge dissection, it should be less than 60 degree or limited within the intima, or less than 2 millimeter length. How to decide the stent size? If you use the lumen, you should use quarter size bigger balloon, and if you use the vessel area, quarter size down, as you may know very well. So this is an initial study compared with EES and SES in Japan, and also if we identify the incomplete apposition about 350 micron, it will disappear during follow-up. That is the reason why if there are 400 micron incomplete apposition, it might be better to treat by using a bigger balloon, higher pressure, or non-compliant balloon. And also, this already demonstrated, if the landing zone is very lipidic, edge stenosis is significantly higher. And also, this is recent data, COCOA study. We compared the OCT guide and angio guide, and this tried to demonstrate a superiority of OCT compared with angio guide. This will soon comes up, and also this ESC Illuminant 4 will be presented. They compared OCT guide and angio guide. We are expecting OCT guide superiority compared with angio guide, but at the moment we have to wait this data until the mid of August, right? So let's move on the case-based discussion, right? That might be much interesting for you. This is a 70 years old male, old myocardial, inferior myocardial infarction, risk factor is hypertension and dyslipidemia. EF is a little bit lower compared with normal condition. You can identify diffuse region, right? diffuse long region, very complex PCI. So in this condition, it might be very difficult to obtain a clear OCT image without pre-dilatation. Therefore, we did a pre-dilatation using a 2.5 balloon, right? And this is an OCT after pre-dilatation. You can identify lots of calcium, but some you can identify the dissection, right? Okay, so I will show you the still frame, right? This is still frame. You can identify lots of calcium here and here and here and here, but each calcium angle is very small, right? Less than 90 degree, but sometimes multiple calcium, but it might be okay. The calcium angle is less than 90 degree, and yes, some parts are very thick, more than 500 micron, but in total or evaluation, the calcium score is less than 3, right? No, 4, right? Therefore, you can make a big lumen area by using a bigger balloon, higher pressure in this condition. So please keep in mind, try to procedure, make it very simple, not too complex. Therefore, imaging is very important to the complex PCI to very simple. So again, how to decide the stent size? Proximal lumen is 2.5, just proximal LED. Still, there are some plaque, but it might be difficult to put crossover the CX because size mismatch in left main and LED. Therefore, we try to put the stent at the just proximal, and distal part is 2.07, and we can measure the vessel area if we want, but based on the lumen 2.25. But generally speaking, and 48, so we selected the two stent strategy in the 2.5 in the distal part and 2.75 in the proximal site. Okay, so try to select the stent size and decide based on morphology, length, and diameter before putting a stent, right? MLD, right? And then, as I told you, the 2.5, 26, and 2.75, 26, because in the proximal site, we want to have nearly 3 millimeter in diameter in the proximal LED. And this is yes, after putting a stent, right? Okay, it looks position is okay, and some under expansion here, right? This is a still frame, and proximal side lumen diameter becomes 2.9, nearly 3 millimeter, and also distal portion 2.23, 2.25 is okay, acceptable. There are no significant dissection, and only the problem is a little bit under expansion. However, here we have a very big calcium, thick calcium, and the opposite side is completely normal. If you dilate aggressively in this portion, we worry about the perforation in this portion. Therefore, it is not enough by the area stenosis, but the diameter stenosis might be more than 80%. So we accept it in the condition. So as I already showed you, how to optimize finally in this case more than 4.5 square millimeter in diameter, the area, and also the no malposition and no dissection, so it might be acceptable, right? So finally, after stenting, we have to check the medial dissection and apposition, and also the expansion. Expansion is very important to avoid the restenosis or subacute or acute stent thrombosis. So try to check the expansion. And I would like to say MLD max, not a 2 pullback, a 3 pullback is very important. During procedure, we try to check by OCT. So we often use 3 pullback, pre and during and final. That's enough, right? And let's move on to severe calcification. Why we have to focusing on from this morning we discussed a lot about the very more than this is a 270 degree very thick calcium. If you put a stent in this condition, the vessel enlarge the opposite side of the calcium, and it might be very difficult to obtain a good lumen area. And if you dilate more using a bigger balloon, higher pressure, there are some risk of the perforation. And therefore, it is very important to think about the calcium condition in detail. And if you try to put a stent, it is very important to confirm the fracture of the calcium plate. Otherwise, we cannot get any good stent area, as you may know very well. So after making a crack, you can obtain a good stent area and very good symmetricity. This is already Dr. Patel showed you in the morning. If there are calcium fracture, minimum stent area is bigger and stent expansion is better, and binary restenosis and TLR is significantly smaller. Therefore, anyway, it is very important to make a crack using a non-compliant balloon or cutting balloon or squaring balloon or IVL. Anyway, you have to identify the crack before putting a stent. That is a key issue in a complex PCI. So if there are less than 500 micron thickness of the calcium, you can make a crack. Anyway, and this is another data from a Japanese colleague. If you use a scoring balloon, nearly 500 micron and also more than 270 degree, you can make a crack as shown in this slide. And this is a summary of Dr. Fujino when she was in CRF. They tried to check the calcium by its angle, from 0 to 2 point, and also the thickness 500 micron and length is 5 millimeter, and from 0 to 4. And if there are 0.4, it might be better to make a calcium modification before putting a stent for making a crack. And now we have an IVL. It is very useful. This is a recent data from our colleague. If there are superficial calcium, calcium fracture is only 30%. However, if there are superficial calcium and absence of nodular calcification and minimum calcium thickness is less than 500 micron and calcium angle arc is more than 170 degree, you can make a crack more than 80%. And we already discussed about the nodular calcium. It might be very difficult to make a crack nodular calcium itself. We can make a dissection near the calcium. So this is the example, eccentric calcium. We can make a dissection, just the edge of the calcium. If the calcium, very thick calcium is about 180 degree, but if you make a fracture, the dissection, you can dilate this direction. And also, if there are circular calcium, you can make a crack by IVL, and you can obtain a good stent expansion. And also, a similar analysis demonstrate nearly 600 micron might be possible to make a fracture, but there are some difference between from 400 micron to 700 micron. The best cutoff in this case is about similar, the 500 micron and also 170 degree, as shown in this slide. Compared with previous analysis, the much thicker calcium can be make a crack by IVL. So IVL should be much more effective to make a crack in the very thick calcium compared with cutting balloon or non-compliant balloon with high pressure, as shown in this slide. And there are some recommendations about the calcified lesion treatment. it was proposed 2019 in JAC intervention. It is very important to check the balloon crossability. In this morning, if there are if we cannot cross the balloon at the site of the calcium, we highly recommend to use the rotablator. But luckily, a balloon cross the region. Therefore, we selected this approach, and then pre-dilatation, we can check intravascular imaging, and then if there are enough, not a significant calcium, we can use non-compliant balloon or cutting balloon and making a good opening of the balloon expansion. And if there are deep calcium or very thick calcium, try to use the rotablator. And if there are no balloon crossability, you try to do the rotablator or orbiter first, and then check the intravascular imaging. And if there are still lots of thick calcium more than 180 degree, try to do the IVL. But if you identify the good balloon expansion and then check the calcium fracture, you can put a stent. If there are no fracture, I think I do not want to recommend you to put a stent, because there are lots of risk of under expansion and making a stent thrombosis and stenosis. At that time, try to do the drug-coated balloon and leave it alone, and try next time, okay? And the problem is the calcified nodule. There are lots of misunderstanding of the terminology. The Renew Vilmani always explain us the calcified nodule is elapsed type, and nodular calcium is simple protrusion of the calcium mass to the lumen. That is the very simple nodule, calcium nodule. It might be easy to make an ablation by rotablator or orbiter, and then we can put a stent because opposite side of the calcium expand. The problem is the calcified nodule, elapsed type. If you try to do the ablation or IVL, if you put a stent, there are lots of tissue protrusion inside the stent. That makes a new calcified nodule, and restenosis will happen. So restenosis ballooning, there are continuous trouble. So at the moment, I do not have any good idea how to treat the calcified nodule. Therefore, after ablation by rotablator or orbiter or laser atherectomy, we try to do the drug-coated ballooning and then follow. Because if we put a stent, we have no good idea to treat the stenosis. So the bifurcation region, physiology guided bifurcation treatment is recommended from my friend in Korea. But look at this data. Within 3 years, actually the higher FFR is very good result. But here some event after 3 years, what really happened? Because if there are metal carina in this condition, this is low shear stress and making a thrombus formation and organized, and you may have a new carina because the area loss can be identified. There are complex gelled type strut at the carina site. And today also we discussed the ideal portion to make an kissing balloon technique, try to select this cell. And this is one of the example, right? Initially we try to select the distal cell, however wire is in the proximal cell, and here might be a link here. And if we dilate here, we make this conformation, we make some deformity in the stent, and it may cause the worst prognosis. Therefore, try to select the distal cell and do the kissing balloon. We can get a good the bifurcation area as shown in this slide. Technically, if it is difficult to select the distal cell, you try to use the double lumen caster, Crusader. You can push in using this guide wire, and then take out, and you try to push in the new wire through the distal marker, and then try to push in the wire here. And if you push in, Crusader never goes in. At that time, you succeed to select the distal cell, right? And then you can get this image by OCT. And try to confirm, use the short axis view as shown in this slide. We already discussed in the morning. Yes, if there are link free, it might be very easy to select the distal cell after part. We can get enough cell area, and then if there are link at the side branch orifice, even if you select the distal cell, if you try to do the kissing balloon, you may have a cell deformity in the main vessel, and still there are lots of metal at the site of the orifice. This is the worst result. Therefore, if you cannot select the proximal site, as shown in this slide, you leave it alone. It might be better for you to avoid this problem, right? This is initial pilot study. Our friend already demonstrated. If there are link free, you can get an optimal result more than 90%. Even if you succeed to select to put the link free and link connecting is by chance. If there are two links, it might be better to have link free, much higher rate, right? And even if you link free, if you do not succeed to select the distal cell, the result is very not good. So link connecting type, do not do the aggressive kissing balloon, because the suboptimal result can be expected, right? And so if there are suboptimal results, there are lots of jailed strut at the side branch orifice and instantly stenosis. In this case, the numerically high, but statistically no significant because of the lower number, only less than 100%, 100 cases. And then we try to do the similar study up to the 600 and 200. We leave it alone as a control, and 400 try to do the kissing balloon as shown previously. And this is a result because we haven't enough experience. If there are link-free type, we succeed the distal cell selection now, and link connecting type, the suboptimal result can be identified as shown in this slide, and the final result can be obtained soon based on this study. And finally, ACS, as you know, the Minoka is an angio-based diagnosis, and in this case they did an OCT and MRI. Finally, they identified some disease by OCT and MR, and this is the final result. OCT and MRI demonstrated some abnormality in more than 80%, and 75% were ischemic, right? And residual is non-ischemic. OCT demonstrate some small rupture or hematoma or irregularity or some abnormal findings as shown in this slide. And therefore, based on these data, expert consensus demonstrate if there are calculate region by angio. Anyway, you try to do the angio and obstructive coronary artery disease, and you can identify the culprit. You try to do the PCI. However, it is ambiguous or a non-obstructive coronary artery disease. You try to do the imaging and then try to decide the culprit site and disease condition by OCT or IVUS. You can easily identify SCAD or subabnormality, yes, as shown in this slide. Okay, and also the ACC and AHA recommend to use an intravascular imaging to identify the culprit site if there are no significant disease by angio. So MINOCA is about 5 to 15% in AMI cases by angio, as you may know. So at that time, it is very important to use an intravascular imaging. This is my take-home message, imaging-guided PCI, a holistic view. I would like to say imaging guide PCI demonstrate better clinical outcome compared with angio guide, especially in case with optimal result, and how to obtain the optimal result by imaging guidance should be the most important point, and imaging guide PCI is becoming more popular in daily our clinical practice by the guidance, guideline recommendation or expert consensus as class 2A, and consensus document regarding OCT guided PCI has described recently, and much more precise PCI could be expected by OCT compared with IVUS guidance in specific regions such as diffuse complex region, severe calcification bifurcation region, and so on, and OCT may allow us to change our daily clinical practice in PCI. Each modality may have an advantage and disadvantage. You can choose either one, depend on the condition. Randomized prospective study should be performed to demonstrate the advantage of imaging guidance, especially in OCT guide for specific pathological conditions such as bifurcation or calcium or something as a game changer in the field of PCI. Thank you very much for your kind attention.